Good afternoon, all. I have been asked to take a topic that is in connection with both hematology and biochemistry immunology. So I selected this topic. I have nothing to give extra than what is already known, but I'll put some challenges so that we can think about the future. As I was been listening to all the talks until now, and the two wonderful talks that just completed also, we need to look forward what will be the future, as we were all already discussing about the artificial intelligence, scope of artificial intelligence, and the era going to come. First of all, let me thank Mindray for inviting me and giving me this opportunity to be in front of you. RDW is not a diagnostic marker, but it's a prognostic marker. Like we use ESR. We don't know why we use ESR, but every CBC will add with an ESR, but that will help as a prognostic marker. Then came the CRP. Now RDW is commonly being used. In 2012, I could actually do a study in RDW. Before I place this RDW topic, let me say that science has two ways of answering questions. Like you have the knowledge that you translate into your daily work. You do your daily work, that data can be made into a knowledge. Both has to go hand in hand. Now we have this opportunity of what is called artificial intelligence handling large data. One example that we saw that in some laboratory where there are huge amount of tests, huge number of tests being done, we are not able to sit and evaluate it. I am sure that the auto verification can do. The question how far it is accurate, definitely it will be better than human at one time, not now probably. Looking at RDW, we know what RDW is. It is the variation in size. I was discussing with some of the pathologists in the morning that there can be difference because RBC lifespan is 120 days. So there will be difference in size, and that difference in size shows that something is going wrong. So this calculation of our bringing the idea of RDW like the other parameters like XYZ parameters that we see was once a new parameter. If you look at the history of RDW, it started coming in publication in 1980s. In 2010, it started picking up in PubMed. I have published an article in 2012. So the first calculation regarding RDW was initially proposed by Coulter. Still, Coulter follows the same technique of calculation of RDW. Now we know that Mindray uses a different technique by which the calculation is made. This is the article I published in 2012 that continuously get momentum of referring this article in multiple journals. We have two measurements in RDW. The common measurement that we take is the CV percent is 11.5 to 14.5%. I am not a hematologist, neither a pathologist. I just went through the content and understood this thing in detail. When I looked at RDW, all the articles that was published in PubMed until today, I found that this has multiple connection with multiple type of disease. As you know, RDW was initially used along with other parameter like MCV in order to classify anemia. That everybody knows and uses the same. But how far it is connected to biochemistry parameters and how it is connected, what are the other common biochemical and immunological parameters that can be connected. When it is macrocytic, the elevated RDW and high MCV can be connected with vitamin B12, folate, MMA and homocysteine. And immunologically, erythropoietin can also be measured. The other tests have been mentioned there. So what problem we have currently is that biochemistry started expanding in its own way. The pathology started expanding in its own way. and microbiology started expanding in its own way, we are dividing. There is no common platform by which this can be combined together and looked. I know that some laboratories doesn't have even access to other domain laboratory tests. They have only access to their domain laboratory test. So such comparison cannot be done. Now using the auto verification, now it's possible that you can connect, because it's a auto verification algorithm is defined by the laboratory, not it's a fixed one, so that you can go for independent verification of other tests from other domains also. So these are the anemia parameters, why it is connected and how it is connected. I am not going to the details of that. I have placed the references of that also. I am not going to the details. My aim is not to bring this into the forefront. I'll come back to that later. RDW has been discussed much in cardiovascular diseases also. It is considered as a prognostic marker in CVD also. Elevated RDW is seen in heart failure, ACS, and in hypertension. My article was in hypertension. The other parameters that are connected with the CVD is definitely the CRP, N-terminal NT-proBNP. Then you have the hemoglobin direct, then platelet count, lipid profile, etc. How it is connected has been mentioned in detail there. It is connected to the inflammation. Recently, I was going through the inflammation statistics across the diseases. You like gut microbiome. We are talking much about gut microbiome. Like that, inflammation is going to be a key factor in the health and the disease process. Almost all diseases are connected with inflammation. Almost all diseases are connected with the oxidative stress that we are undergoing. I was talking to Dr. Sharma that you don't worry about things that are going wrong, because that will increase your inflammation, that indirectly cause RDW changes. Beware of that. Okay. It is increased in sepsis. It was a marker in COVID-19. It is increased in rheumatoid arthritis, and its connection is well documented with other biochemical parameters. Among them, recently we found that as an inflammatory marker, interleukin 6 has been coming up across the world, and even many of the companies like Mindray has started producing IL-6 in their equipments. Definitely RDW is a marker for cancer. Many cancer has direct relationship with RDW elevation. Breast cancer, colorectal cancer, gastric cancer, bladder cancer, then all the prostate, you list all of them have some biochemical and immunological parameters that are connected. So I am not going to again into the details of that. My purpose is not that, so I am not going into the details of those individual cancers. So what we have found that why this RDW is increasing, what is the mechanism behind the RDW increase in cancer is mainly due to inflammation, deficiency of nutrients that we were talking, because nutrients are important for these anti-inflammatory activities. Then definitely the bone marrow dysfunction, hemolysis process, and the tumor burden and hypoxia. You cannot exclude any one of them from the other, because these are all together. If you know, inflammation can cause hemolysis, then nutritional deficiency can cause inflammation, though hypoxia can, these are interrelated things that one can affect the other. So now we have the inflammatory marker IL-6. This is the picture I have taken from Mindray. That Mindray immunoassay machine has the IL-6. You see almost every the association of IL-6 with almost every disease there. So RDW is important. A normal RDW talks about good health in most of the cases, but an abnormal RDW talks about there is something bad that had happened. It is not a healthy condition. In disease states, RDW can serve as a biomarker of various conditions, including CVD. What is the implication? The diagnostic utility of RDW can enhance patient assessment and management. But now we know that since that identification, the measurement of RDW is not very robust, that may not directly give a clue. So they have, some of them have created some ratios like RDW platelet ratio. I've seen that many diseases are connected with the RDW platelet ratio. There are many studies that was published in PubMed regarding RDW platelet ratio, RPR. You can see the list of diseases there. So I just went through a study in order to see, because the two methodology between the Coulter and the Mindray is different. They are related, because I am using both the Coulter equipment DXH800 and Mindray 6800. Absolute values were slightly lower in Mindray, but slightly higher in the Beckman Coulter equipments. But the correlation was perfect. The correlation was perfect. Even though the absolute values were slightly different, the correlation was perfect. I had lot of queries on this. I went into the internet and searched. Almost last 6 months I was trying and learning artificial intelligence in deep, so that we were thinking what can we do for the future. When I looked at RDW, I found a particular repository called RedTel that analyzes the morphology of RBC. This is an open source repository available in the web. The data is available in GitHub. You can go to that link, and there are repositories available that can be downloaded and used for analyzing the RBC. As it was discussed in the morning today, we have only few cells as WBCs, but the number of RBCs are in millions. In order to analyze them through a microscope by a pathologist or a hematopathologist is going to be very difficult. But if it can be done by an artificial intelligence that can view each and every cell and measure its and identify the abnormality, what the world would be. And I have gone through some of the softwares who are already trying analyzing hematopathology as well as the pathology slides. I have listed them. I have two questions and challenges that has to be raised to you. As it was mentioned by Dr. Sugesh in the morning, we are laboratory clinicians. We cannot be separated as biochemists, microbiologists, and pathologists. We have to work together for the betterment of the future. As lab clinician, I also want you to create a society of your children who are techies, who can understand you and create better future of. Thank you.